afternoon. My name is Shrews Jansen Van Buren, and I am a student physical therapist. Today, I'd like to discuss my patient with back pain. Back pain is extremely common in America and debilitating, and it limits quality of life greatly. Our patient is a 24-year-old OT student, occupational therapy student, complaining of an aching low back pain and tightness that increases with prolonged standing, prolonged walking, and general extension activities. She rates her pain as low and nagging. She states she cannot run because of the pain, but she exercises using an incline treadmill and walking, which basically facilitates lumbar flexion for her. She states that when she sleeps in a fetal position on her side. She does not sleep on her back because of the pain. And basically, we see that this patient lives in lumbar flexion. She does not like extension. She claims multiple times during the interview that she feels constantly like she needs to bend forward to ease the pain and open up the area. Other than this tightness, she describes, patient states that sometimes she feels as if her left low back moves in and out of place. Lastly, patient adds that she was diagnosed with structural scoliosis and wore a back brace for 3 years from grades 6 to 8. Before starting the examination, patient filled out the FABQ from Waddell et al. In 1993. This is a questionnaire consisting of 16 statements about fear avoidance based questions, and it relates to how the patient perceives her pain and how it relates to function. And this patient is asked to describe how they agree with the statement on a scale of 0 to 6. Points are added up and scores greater than 19 mean an increase in fear avoidance behaviors. Patient scored 15. Most of the points added up in sections of statements believing physical activity caused or exacerbates her pain, so she's afraid of physical activity. Patient stated that her goal was to be able to be on her feet for prolonged periods, to work as an OT in the future, be able to tolerate standing and walking. Upon structural inspection, her left scapula was in a higher position than the right. Her left iliac crest was also elevated compared to the right, and there was bilateral scapular winging. Palpation revealed a dextroscoliosis, meaning a right convexity, in her thoracic spine. There was decreased lumbar lordosis in standing. Her active range of motion is significantly limited in left rotation and backward bending, but no pain. Passive range of motion showed hypomobility in her mid-thoracic spine, and lumbar segments L3, L4 showed reactive muscle guarding when I applied a force on the transverse process mimicking left rotation. Patient complained of pain at this point. Neurovascular screen was negative for numbness, tingling, radiating pain, normal reflexes. Her upper and lower screens were also negative. For special tests, I was suspecting instability, and I did the test for aberrant motion to test for this, and I instructed the patient to be standing and bend over and return upright 5 times quickly in sequence, and I watched for muscle juddering in her back, and the patient was positive, indicating possible instability. Prone instability test, in which the patient lies prone on the table and holds onto the table, lifting both legs up at the same time off the floor. Patient reported pain in this position at that same L3, L4 region, so I applied a downward pressure to stabilize L3, L4 region, and I had her repeat that test again. She claimed that she felt better this time, and this is a positive test for this test. It indicates the patient will likely benefit from a stabilization program, according to Hicks et al. In 2005. Thomas test was done because I suspected her hip flexors might be tight since she likes flexion so much. Patient holds her one knee to her chest and lies supine, and the other leg is left to dangle off. I measured the knee flexion at the other leg dangling off the table. Less than 80 degrees of flexion at that knee means tightness in the 2-joint hip flexors, and patient measured 50 degrees bilaterally hanging in hip internal rotation, meaning the tensor fasciae latae muscle was tight. Transverse abdominis drawn with blood pressure cuff was done to test the strength of the transverse abdominis. She was only able to hold at 44 millimeters mercury for about 10 seconds. Ideally, we would want her to hold for 15 seconds and repeat this in segments of 2 millimeters mercury increases. So this test is done. Patient is lying supine, and the blood pressure cuff is inflated to 40 millimeters mercury and placed at that L3, L4 level, and she watches the pressure change and tries to control the motion. She showed weakness in transverse abdominis and lack of control. So from her subjective, complaining of pain, prolonged standing, needing to constantly adjust and bend forward to relieve her pain, and also the muscle guarding and hypermobility at L3, L4 I found in the passive mobility testing, we can conclude that she has an instability at that L304 segment. This is also likely caused by her not having a lot of motion in her thoracic spine and making up for that motion in her lumbar spine. So, patient diagnosis was based on ICF classification, the International Classification of Functioning Disability and Health by the APTA in 2008, to diagnose patients' health condition as it applies to functioning in life. Her diagnosis based on the ICF was low back pain with movement coordination impairments, meaning instability. Patient has a good prognosis. She's young, she's motivated, she's an OT student, so she knows how important movement is. She's likely to stick with her program. However, she does not have an excellent prognosis because her problem is stemming from a structural scoliosis that we cannot fix as therapists. So that is not going to really get better. Her long-term goals in PT will be that in 8 weeks she'll maintain contraction of the transverse abdominis and supine with a blood pressure cuff at 46 millimeters mercury for 15 seconds to demonstrate adequate TA activation and strength to provide this dynamic stability to L304. The impairments we found included, first of all, the hypermobility instability at L304, which we will treat with dynamic stabilization using the TA activation. So she'll be hook lying and having the blood pressure cuff under her back as we described earlier. This is supported by the article A Clinical Prediction Rule to Identify Patients with Low Back Pain Who Are Likely to Experience Short-Term Success Following Lumbar Stabilization Exercises by Rabin et al. In 2014. We will also use multifidus training for dynamic stability, Lebrivier et al. In the article The Effects of an 8-Week Stabilization Exercise Program on Lumbar Multifidus Activation in Patients with Low Back Pain showed a positive correlation between multifidus inactivity and low back pain, finding patients benefit from strengthening and training the multifidus muscle. Multifidus is targeted in a quadruped position, and the patient will perform a shoulder flexion and the contralateral hip extension. So she'll kick her leg back and lift her shoulder at the same time, and she will perform this for about 3 sets of 10, holding for 3 seconds at the end of that range. The next impairment we found was a hypomobile mid-thoracic spine. We will treat this with mobilization with movement in the T-spine as suggested by Lewis et al. In 2014. In their article, A Preliminary Study to Evaluate Postural Improvement in Subjects with Scoliosis, they found that mobilization with movement helped all subjects show improvements in ranges of almost every direction and improved pelvic alignment. Patient will stand facing a wall with a bolster around her thoracic spine, and the bolster is attached to a fixed point on the wall on an incline with a rope, and the patient is instructed to put her hands behind her neck and facilitate backward bending while the bolster resists. So this mobilization with movement is going to help her to participate in her mobilization, use muscle activity to drive that range, and they recommended 10 repetitions 2 times a day for the results that they witnessed, so our patient will perform the same. Also, to target the T-spine hypomobility, we can use a stretch over a bolster, using right side lying with the bolster placed under the apex of the curvature in her thoracic spine. Musculino et al. In 2018, in their article Scoliosis Clinical Orthopedic Manual Therapy Treatment, suggested that stretching over a bolster on the side of convexity, our patient's right side, will help to actually lessen the curve of the scoliotic spine. This patient can rest in this position for 5 minutes. We can take her out and assess how she's doing, and she can continue for 20 more minutes until she feels a good stretch. The tight bilateral TFL or tight IT bands we will treat using the same Thomas test position that we used to test for the length, but I will apply pressure into knee flexion and some external rotation at the hip to target the tensor fasciae latae. We will hold for 30 seconds and do 5 repetitions. With the stabilization program and the thoracic mobilization, I believe that the patient's pain will decrease in 8 weeks and she will reach her goal. She will have a better quality of life without this low back pain and hopefully be able to return to running and participating in her occupational therapy program and be well on her way to a pain-free lifestyle. Thank you for your time and attention. This concludes my presentation.